board member here with us today, Mark Schwartz. He is the owner of Harmony Place, who does wonderful work with eating disorders, and he is one of the most passionate people I have talked to about his work. It's really wonderful to see. So without further ado, I'm handing it over to Mark. Dr. Mark Schwartz.
Okay, I'm really excited to be here, and I really appreciate you all coming. And I'm going to have a lot to say because this field has changed so rapidly and radically. And I'm a firm believer, I was there sort of at the beginning with Masters and Johnson, so I'm a firm believer that the splitting of the sex therapy and the marital therapy fields was a huge mistake. And that all marital therapists need to be sex therapists, and all sex therapists need to be marital therapists. And, it's just too bad that that hasn't happened. Anyway, so where I want to start is that when I saw this slide, it really took my breath away, because this is a picture of the brain with women watching highly erotic movies. And what's so interesting is that sexuality affects the entire brain. We're so used to saying, well, where does the serotonin reuptake inhibitor work? And where does, what part of the brain? And, we have this illusion that we understand stuff because we understand, the prefrontal cortex and also on. But, all this stuff is affecting all parts of the brain and lots of different ways. And why that's important, you're going to see, is because I'll tell you, I'm a sort of a radical, I guess, because I think I've read everything that's ever been written in the area of sexuality and sex therapy, and I swear to you, I've not found anyone who gets it. And, I didn't get it for most of my career. Actually, working with eating disorder clients, I began to understand something about women and their bodies that I never quite got as a male, number one, and number two, even as a sex therapist. And so there's just lots and lots to be able to understand. And I'll try to convince you that having done this for more than 50 years now, the more I know, the less I know. And that's the problem, is that I used to be a cognitive behavioral therapist and do really good work, and then I got in recovery and realized that cognitive behavioral therapy is necessary, but not sufficient. So don't in any way throw pies at me, because I'm going to try to convince you that how I think about this. Okay, so let's just begin and get right to it. So orgasm. So you have a PowerPoint, you can just follow me. And the other really interesting thing, 63% of women reported arousal and orgasm problems. These are reliable data. We're talking about meta-studies across the United States. 63% of women report arousal and orgasm problems to their standard gynecologist, even though they're happily married. And 85% of them reported that they were satisfied with their sexual relationship, even though they weren't. The correlation between the pubococcygeal muscle tone and orgasms is low. So the reason I put that in there is that, there was a lot of emphasis on, pubococcygeal exercises and teaching women to be orgasmic. And could it be that maybe we're wrong? That maybe the male model of ejaculation doesn't apply to women, and maybe orgasm with intercourse isn't exactly normal. Because how many women come in and say, I'm not orgasmic with intercourse, what's wrong with me? And what if being orgasmic with intercourse isn't normal? That maybe the normal state is not to be orgasmic with intercourse. Could that be? Let's follow that. Well, so anyway, what it says is that that if you go into a gynecologist's office, that you find that there's sexual desire, there's sexual arousal, and there's sexual response. Sexual desire is initiatory behavior, sexual arousal is how the body turns itself on, and then sexual response is orgasm, so on. And without going through all this stuff with you, I just want to say that that it's very, very common that women are not enjoying their sex life. And if you do sampling of women across the United States, I'd say we have an epidemic of women who are in relatively happy marriages who are not enjoying their sex life. How many? Probably more than a third. And so it's a ubiquitous problem. And the question is, why? What is going on? And if it's such a common problem, how does it affect marriage? Is it that important? I'd say it is. I think sex is a very important part of a marriage. And if a couple comes in and has marital problems and they're not having a sex life, I think that's a big issue. And that's not a judgment. There are lots of data to support that a happy marriage includes having a good sex life. So how do you want to think about this? There's kind of a revolution in thinking about this. There was this book that came out called Come As You Are. Anybody read that?
Oh, yeah.
Yeah. It's a really important book. And what it's about is that basically there are ways of thinking about sexual desire and arousal. Is that there's an accelerator button and there's a brake button. So let's imagine that your accelerator and your brake of your car are going at the same time. What would happen? You'd be imploding a little bit. Make a lot of noise and making a lot of noise, but you wouldn't be going anywhere. So on the accelerator side, what makes sex good? Well, being able to love your partner, being able to love, period. We assume that people can love. And I'm going to be telling you by the end of this talk that I think that one of the big issues is that many people have a really poorly differentiated sense of self. They've never individuated. And they have great difficulties in actually loving another human being because of their own self-focus. And that is one of the big factors that keeps a person from being able to enjoy sex. But we'll step back from that. What's on the accelerator? You have to be able to be in good health. You have to be able to touch your partner. You have to be able to enjoy the sensuality of it. You have to be able to enjoy your body. So, anything that allows a person to be able to flow, let go, dance, play, laugh, have fun, be intimate, connect. All those things are accelerating. What are the brakes? Kids, right? Kids screw up sex. And everyone knows that, and the data on that is really clear. So how to deal with that is an important problem. Brakes. Trauma is a brake, obviously. Being able to not be nude is shame, feeling defective. So if you want to think about how to be able to work with somebody, the first level is always increase the acceleration, decrease the brakes. But in your assessment, you have to look at the full range of what's accelerating and what's braking. Now, what happens with most people is they're both going at the same time. And so if you think of, like, for example, sex addiction. With sex addiction, a person will say, I am really highly aroused with call girls, but when I'm with my wife, I can't get aroused at all. And so somebody who's hypersexual is also hyposexual. And so you've got somebody who's the brake and the gas is going at the same time. And that's a bit of a mess. But we're not used to thinking of that. We're thinking, oh, people are hypersexual or they're hyposexual. But what we're finding is that most people are both, depending upon the situation and who they're with. And it's important to look at those in some ways. All right. Now, so if you're looking at, kind of a list just for your own OCD, here are some things that could be important. One of the important ones is the imago. And the imago, as you remember, is what turns a person on. If you go into a room with 100 people, how many of those people are you going to want to go out on a date with? We're very picky. And what determines what turns you on is your love map. A love map is a template in the brain of that which arouses you. And people's love maps are really interesting and confusing, because what's happened today is that more and more kids are watching pornography from age 9, 10, 11, and 12. And a lot of girls are watching pornography. And so the statistics are that a lot of women are looking at pornography. And so we're getting, I don't know about you and your practice, but my practice, I get sort of a whole epidemic of couples coming in who are, kind of early in their marriage, and they can't get aroused by each other because the man has been looking at pornography since he was 11, and what they do is they edge it, which is, they look at pornography for 3 hours, at 11 o'clock at night. And of course, I'm an old timer, so like, what are you doing for 3 hours? Like, I'm trying to imagine, like, how does one do that, So they have to teach me how you can masturbate for 3 hours. But more important is, what does that do to the body? I mean, imagine, edging it where you're looking at one thing and then another thing, another thing, another thing, another thing, another thing. And what that would do to the brain. And so the brain needs more and more stimulation in order to get aroused. And so they get into bed with their partner, and for some reason, they're not very turned on. And they want you to be able to fix that. Right? So we're seeing a huge amount of that. And what seems to be happening is that the brain is being hardwired to the computer screen, and it's not being hardwired to touch. So the haptic sense, touch, is what most of us are used to thinking of, an essential way you touch somebody and they turn you on, because the sensuality goes from your fingertips up to your brain, and your brain then interprets that in a sexual way. But if you touch somebody and it doesn't turn you on. Now, pornography is an example of that. But guess what? What's the leading cause of an inability to be aroused by touch? Disorganized attachment. Okay? If you give somebody the adult attachment interview, and you record that they have either an avoidant or a disorganized score on that, and then you ask, let's say, a 13 to 16-year-old, what happens when your partner touches you? They'll say, I'm numb. I don't feel anything, and I don't know why everyone's talking so much about sex. I don't see the big deal. It's no big deal. So they'll have sex because they want to keep up with their peers, but they don't seem to be getting much out of it. They're numb. Isn't that interesting? So here we are, and they're coming in, and they're saying, I don't, at an older age, I don't know why I'm getting turned on, and we want to do something to amplify it in some way, but the problem is in the attachment system, not in the genitourinary system.
Can we ask questions as we go
Yeah,
along?
of course.
I'll say I make a distinction between pornography and arousal. So everybody says pornography, and I see pornography as, demeaning, violent, or whatever, whereas erotic is, whoa,
Yeah, I mean, there's a lot to be said for that. And, we could have a whole separate discussion just about that, because objectifying people is not exactly what we're about. Sex is about relationship and intimacy, and all that, takes it out of that context. And it's not that I'm down on pornography, because I think sometimes in the old days it was ignorance. We didn't know what to do, so people are at least learning what to do by watching it. But the point I want to get to you is that you're going to see in your practice, if you haven't already, a whole epidemic of young people coming in with huge problems. And it has its origin in this way. And I'm seeing a lot of marriages break up because one partner is really hurt and devastated by the partner not being able to turn on to them. And it's really very sad. Now, it is fixable. That's the good thing. Mother Nature is very robust. And a lot of the techniques I'll be showing you really do work with these folks. Most sexual problems are reversible. When we worked for Masters and Johnson, good 80% of people we had success with, and we're still keep that. Lori and I, those of you who don't know Lori, my partner, we've been doing this for more than 30 years, and we work as a co-therapy team. I see him, she sees her, and when we both focus on the relationship. And we do co-therapy work, and we typically do about 10 to 12 sessions. It's time limited, intensive, and we usually see them twice, 3 times a week for a short period of time. So in a month or 6 weeks, we can fix most sexual problems, I would say, with very high success. But what we're doing now is really different than what we did 30, 50 years ago. Because most of those people have a history of trauma and disorganized attachment. And so we're having to do all the things that we used to do, but a lot more. And I'll try to show you what that is. Okay, so direct masturbation is most frequently used with primary anorgasmic women. So we're not seeing as much of this as in the old days. Women are masturbating, and they're masturbating at an earlier age, and they're teaching themselves to be orgasmic, whereas 20 years ago, masturbation was pretty much taboo. A lot less of that these days. Adolescents are almost all are masturbating 80 or 90%. So that's where there's a real sexual revolution. And most women, if they haven't been orgasmic, they can learn in pre-orgasmic women groups with a little bit of information and support. So it's a matter of finding sufficient stimulation. So I've always used the height report as kind of an old but basic premise, because in it there's 100 women talking about how they are orgasmic, and they give you direct, really information. Some women use their knuckles, some use their fingers, some use it. But a lot of it is being able to get the freedom to explore and experiment, and that's what pre-orgasmic women groups are able to do. Now, what's happened, as you may guess, is the pharmacological revolution. And so we used to go to conferences and trying to figure out where to invest in the stock market, because after Viagra came out, we thought, my God, as sex therapists, we ought to be rich, right? Because we knew that was coming. So we didn't want to miss it when they came out with the Viagra for women. And I remember the first conference we went to, they came up with apomorphine. And they'd say, this works really well. It takes women and increases their sexual arousal enormously. There's only one small side effect, which is they throw up. But they don't seem to mind a lot. And we decided we're not going to invest in that stock. Okay. Apomorphine has not taken off. That was supposed to be a joke. Come on, you can laugh a little bit. Anyway, so nowadays they came out with this bromolantone. They always make it so you can't pronounce it. And everyone got really excited because we finally have a drug for low sexual desire in women. About 25% of women who took reported some increase in sexual desire, compared to 17% of those who took a placebo. What do you notice about those data? And that, a lot of them get some improvement from it in some ways. So, but it hasn't taken off, and I'm going to tell you why I think it hasn't taken off. At least 48 minutes before anticipated sex, a woman injects the medication into their thigh or abdomen, or a partner can do this. No one knows precisely how it works, but it does activate these receptors. Okay, so it reminds me of the good old days. In the good old days, I used to work in a urology clinic, and implants were very popular. And we gave probably 1,000 implants out. And everyone was really excited about, it could just, get their little thing, whoop, it goes up, whoop, it goes down. And it was really cool, and it was very exciting. But you know what? Nobody was using it. They would have fun playing with it, but they weren't using it for sex. Anybody guess why?
Attachment? Attachment?
Their wives didn't like it. It's like, are you interested in me? Or that button you keep pushing. It's like the remote on the television set, right? And women were saying, I don't feel desired, by you using that remote control. Get it? So no one thought to ask the wives, how do you feel about your partner having an implant? And so of the 1,000 people who got it, like 900 of them weren't using it on an ongoing kind of basis. Isn't that interesting? And that's what's happening, it's like people get really excited about the idea of being able to put some of this in, but it doesn't seem to be very functional because they don't do an analysis of how people use this stuff. So anyway, there is a bunch of drugs out now that do increase sexual desire in women, and I've sort of given you the names of them here. And one you can just use nasally, which is kind of a little more convenient. And it's good to know what they are, and it's good to begin to get some use with them. And I'm going to try to show you, as this lecture goes on, why I'm not really enthusiastic about this. Because I'm not looking for the mechanical way to turn women on. What I'm interested in is understanding the accelerator and the brakes. And the idea of sort of putting your foot harder on the accelerator without really attending to what's going on in the brakes, it doesn't seem to work very well for me. So we'll get to that. But before we do that, let's say something about men, which is that impotence, as you can see, increases with age, and that by age 70, you're going to have high incidence of impotence statistically in the population. And total impotence by age 60 is 60%. Okay? And these are good data. And it's highly correlated with HDL. So Viagra has been an incredible invention, and it's good stuff, and it's changed huge people's lives. And so there are these different meds for that, and of the ones that you can use, Cialis or Tadalafil is probably the most effective. It lasts the longest, and you can take it, half hour before sex, whereas with Viagra it needs to be 2 hours before sex. So it's a lot more convenient, it's more effective. So if you're looking for one, your local sex therapist recommends Cialis. And it's good. I think that it's good in the sense that it increases men's erectile security. It also increases their desire and arousal a good maybe 20% for most men. So even with low desire, adding a bit of Viagra to the potion can really make a big difference. And it isn't one where it's like the implant where it just makes your penis work. It actually increases the desire and the arousal of the person to their partner, which is a little bit different kind of story and far more useful in some way. Okay, so now when you say, what are the brakes? Let's start with this, that sexuality is basically an extremely vulnerable activity. Being nude with another person, with a light on in the room. If you're in your body, if you're mindful and you're present, it's a pretty intense experience. And so a lot of people dissociate. They just kind of go away. And anxiety then increases that. What would cause anxiety? Is anxiety an accelerator or is anxiety a brake? It's both, right. Anxiety can be an accelerator. New partner. Oh, how exciting. I wonder what's going to happen. And anxiety can be an inhibitor. I'm scared shitless. Okay? So fear will certainly be a brake. So anxiety can work both ways, and actually it sometimes does. So early in a relationship, you can have both the accelerator and the brakes going around anxiety. And so people oftentimes say, well, let's relax. Okay? What's wrong with relaxing in sex? Sexuality is an increase of muscular tension. Okay? And muscular tension is tension. So relaxing may not be conducive to sex. You with me? And so increase of muscular tension means that as you get more aroused, your whole body, the muscles are tightening in some ways. So being chilled is not necessarily conducive to sex. So this thing about how anxiety works, if you're taking anxiolytic, a Klonopin before you have sex, it doesn't seem like a good idea. And so a lot of people do take benzos before sex, and in order to be able to cope. And I'm not saying that's useful, but if your anxiety is so high that you're afraid to be with somebody because of trauma, that doesn't seem so good either, because what you're doing is you're bypassing the natural response. And if you're terrified because of having flashbacks of trauma, and then you push yourself to have sex when your body's not necessarily there, you're going to create sexual aversion. Sexual aversion is a phobic element to sex. And so what I'm trying to do with women generally, and sometimes men, is do not have sex when you can't be present in your own body, when you're not desirous, you're not arousal of it. So many women, go to KY jelly and have sex in order to please their partner, and they're not doing any big favor to their partner because it doesn't feel so good to have sex with somebody who just is being done to, and they're really hurting themselves in some ways. So I want to have a person respect that and not try to bypass that with a drug or with an anxiolytic. Does that make sense? Okay? So it's beginning to kind of get the whole picture here. So what we do is we do Sensi Focus. And Masters and Johnson invented Sensi Focus, but the interesting thing about it is that almost no one got it about what it was. Sensi Focus is not the cure. Sensi Focus is a tool. And in this tool you say, I want you to go home tonight. I want you to touch your partner, head to toe, front to back, in a sensual way, with breasts and genitals off limits. And when you touch them, I want you to be mindful of what you're experiencing through all of your senses. When you touch their face, what does it feel like? When you touch their hair, what does it feel like? When you touch their legs, what does it feel like? When you touch their toes, what does it feel like? I don't want you to give them a massage. I don't want you to try to turn them on. I don't want you to try to make them feel good. I want 100% of the focus to be on what you're experiencing in a mindful way. And tomorrow when you come to my office, I'm going to say, what was it like when you touched them? And I don't want you to say good. I want to know what it was like when you touched the face and how that was different than the arms. I want to know what the experience was like. So, the person sort of looks kind of dizzy, And so they'll come in the next day and I'll say, what was it like when you touched your partner? I liked it. Okay, good. What sensations did you take in? It felt good. Okay. So now what we have to do is get them to go from good, which is an evaluation and a judgment up here, to back in their body. And, to be able to say, well, when you touch this piece of metal, what do you notice? Well, it's smooth, it's slippery, it's warm, it has texture, it's silver, it's, kind of cool. Well, you were just much more descriptive on that piece of metal than when you touched your partner last night. How come? What's the answer to that?
Inhibition? Inhibition?
We're not used to thinking in a mindful way. Like when you dry yourself with a towel, do you actually feel the towel on your body? Do you feel the wetness on your body? Can you feel yourself drying? The mindfulness revolution is teaching people to go from here to here. And if you think about it, that's really what we're talking about here, which is teaching people to get back in their bodies and experience what they're experiencing in the moment. But a lot of people are doing grocery lists in their head, or they're so focused on the goal, which is orgasm, or turning their partner on, that they forget what it's like to have that experience. It's like driving across the United States, but not noticing the Grand Canyon, versus driving across the United States and having a religious experience with the Grand Canyon, and have a Grand Canyon experience in touching your partner. Get it? Okay. So if you can begin that, then what happens is that the magic happens because the person is in their mind and their body. Now, think about it. What is intimacy? What is love? Love is giving 100% of your attention to your child for 15 minutes without your phone ringing, without the television being on, or without them looking in their iPad. 15 minutes of 100% of your attention is an act of love. Okay? So what is making love? Making love is giving 100% of your attention to being connected and close to your partner. And most of us have never had a frame of reference of that, right? And so what the sex therapist is doing is, at some level, bringing the mindfulness revolution into the bedroom and beginning to understand dissociation and understand we're also overstimulated, that we're not used to being able to pay attention to what we're experiencing. Now, at level 1, that's partly what we're doing with Sensi Focus. Now, as I said to you earlier, that was maybe the first 20 years of my career, and that all was really good stuff. But as time went on, that stuff stopped working. And it was necessary, but it was not sufficient. And so Lori and I opened up a trauma clinic in New Orleans, and we began working with post-traumatic stress some 20, 30 years ago. And we tried to understand how you deal with rape trauma. And just to give you some idea of history, when I was with Masters and Johnson, we wrote up a grant for NIH to treat rape trauma, and there was nothing in the scientific literature on how to treat rape trauma. And there was no technique out there for therapists on how to be able to do it. And so we did is we put our heads together as an institute, and we came up with a proposal, and we sent it to NIH, and it got turned down. So I thought to myself, here I am with the leaders, and this is an area that desperately is needed, and it can't even get it funded in some way. And it just shows you how, in the last 30 years, things have changed so radically. But I still think that as everyone here knows how to do trauma therapy. Everybody here knows how to work with rape trauma. But do they? That's the question. And what are the necessary and sufficient interventions? How do you know when trauma is resolved? And the interesting thing is that the lowest common denominator turns out to be sexuality. Because the last thing you treat when you're treating sexual trauma is usually sexual response. Everything else comes before that. So when a person comes in and they have rape trauma or have been molested, and you do sex therapy, you're re-victimizing them. Because what you're doing is you're pushing them into a situation where their body is telling them, I'm not ready for this, and you're imploding them in some way and putting pressure on them. And so the emphasis has been, how do you do trauma resolution work and so on. So what a lot of people were doing is, we're going to do trauma work for the next year. And I'd like you to come in for twice a week for the next year, and we'll do trauma work. And then we'll deal with your partner, in about a year or two. Marriages don't survive that. And so it didn't make any sense that you do trauma work here, and then we get down to do sex therapy or marital therapy a year from now. See what I mean? And so that was the dilemma, how to be able to do that. So the solution was fairly obvious, which was what one has to do is one has to do time-limited trauma work to be able to help a person begin to figure out how to be able to deal with incest or molestation or rape, because almost everybody comes in has been molested or raped like 6 or 7 times. Rarely do you see somebody who's had one experience. You see it compounded over and over and over again. And you could ask the question, well, why is that? And there is an answer to that, which is what we're seeing are high numbers of people who reenact. And so what happens is that they'll be in a dysfunctional family system, and the father will molest them, and there'll be lots of dysfunction, and then they go out and find partners who will abuse them and potentially reenact that in certain ways. And so reenactment and repetition is pathognomonic of trauma. And so most people have had multiple trauma experiences. And so the mission impossible is how to be able to deal with all that trauma and do it in a time-limited way so that the marriage doesn't fall apart. Right? Okay. So you see the kind of dilemmas that have, and honestly, these things are not really talked about much in the field. If you read a book on this kind of stuff,
they don't get down to the common garden variety problems that we experience in our offices on a day-by-day basis. And I think it's a catch-22 and a dilemma for a lot of therapists. How do you deal with the reenactment, the trauma, and so on? So, I mean, just our solution has always been to do intensive therapy. That was our model with Masters and Johnson. We saw people for 2 weeks, time limited over a month. And we've always tried to do that. So, you know, at Harmony Place, what we do is we have people for 2 months. We see them 5 days a week, and we see them for 6 hours a day. And the insurance pays for it. That is a magic, you know, it's really something. Because, you know, we're seeing them 3 times a week in individual therapy. So you can do a ton of work in a 2-month period of time, as much as a year's worth of psychotherapy in a 2-month period, and it doesn't cost them anything. So that was the robust model that we figured out that was optimal and worked in most situations. When we began to do that, what we realized is that most sex problems are love problems. And so, again, the more you know, the more you realize, okay, it's not enough that you deal with the trauma. It's not enough that you deal with the sex therapy. But underneath that is a primary attachment disorder, where they have come closer, accelerated, go away, avoid. And so what we began to do is study this disorganized attachment. And Lori and I got trained in the adult attachment interview and began to really understand what it means to have a disorganized attachment. In our treatment center, what we did is we gave the adult attachment interview to the first 100 clients that we saw, and what we found was that 95% of them had disorganized attachment. And that's what we had suspected. And so we became more and more interested in not only working with the trauma, but also beginning to figure out what to do about these attachment problems, because they're love disorders. The person hates themselves, they feel like they're damaged goods, they hate their bodies, and how is it that they're going to be able to make love with another person when they hate themselves and hate their bodies? Mission impossible. And so it had to be not an interpsychic problem, but an intrapsychic problem, meaning we had to teach them how to have a relationship with themselves and how to be able to love themselves, have peace with themselves, and develop a relationship. And so the motto that we picked was one which basically is reparenting. We were beginning to work with people on reparenting their injured self, and the model that we chose was internal family systems. And so internal family systems in EMDR were really techniques that allowed us to turbocharge that process of working intrapsychically and helping the person begin to not continue to hate their body and themselves and begin to understand this. In this slide, I just wanted to be able to show you the data on avoidant and anxious attachments. And what you see among adolescents is less falling in love, low intimacy, more uncomfortable feelings towards sex, as I talked about, more drugs and alcohol with sex. With the anxious attachment, really an obsessive style of love, of picking partners, falling in love with them, and developing what we call love addiction now. A love addiction is where they're highly dependent personality, they form fused relationships, and they're looking for someone to save them. Those kinds of interpersonal bonds, they can be very exciting sexually, but in the end they blow up. And we're getting now this new epidemic of particularly partners, women, who are going on the internet at 3 o'clock in the morning and doing hookups, you know, using and having people come to their house in dangerous ways. And I'd say maybe a third of the girls that we're seeing, young adolescent girls, are doing hookups on the internet. It's not a low frequency kind of behavior. And it's just terrifying to think about, you know, what that all means in some ways. And so what we do is we teach them what their attachment pattern is, what avoidant attachment is, with anxious attachment, and disorganized attachment is a combination of the two. And inherent in an attachment disorder is what in ego psychology or self-psychology, Kohut and Winnicott were describing as disorders of self. And so the best training for this kind of work is in the ego psychology kind of background. And in it, if you go back and read Masterson, Winnicott, and Kohut, you begin to see that what we have are people who have false selves. Everything is oriented toward, do you love me? Do you like me? And sex is a way of saying, if you have sex with me, then you must like me. And so their sex is oriented to getting someone to like them. And it's very other-oriented. What happens when you're other-oriented is you're not really in your body. And you're not really experiencing it because everything is otherization. Do you like me? 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 That's preoccupied attachment. Avoidant attachment is, you are so far and so distant. A client comes in your office with avoidant attachment, and you're with them for 6 months, and you notice that you don't really have a therapeutic relationship. You can feel it. And, you can do all the right things in terms of how to do therapy, but it's not taking because you realize that you really don't have a true therapeutic relationship with the client. And you all know what I'm talking about. And you wonder, is it me, or is it the client, or do I need to refer them to a different therapist or a different sex therapist, or what? But the truth is that the person has avoidant attachment, and they're unable to attune themselves. And if they're able to that way with you, you can bet that when they're with partners, so one of the breaks is avoidant attachment. But with disorganized attachment, they have both preoccupied and avoidant simultaneously. The accelerator's going and the brake's on. And it makes you crazy. And that's what happens in their relationship. But we never really understood that. Oh, you've got inhibited sexual desire. Oh, you're a sex addict. But sex addicts have inhibited sexual desire, and people with inhibited sexual desire are calling people at 3 o'clock in the morning to have sex with them. And we're having this epidemic of people with sex addictions and love addictions. I don't know if you're seeing it, but there have been times when I may get 2 or 3 referrals a week for this. It's just off the charts. Whereas years ago, we weren't seeing it at all, and particularly among young people. Now, you think about what's happened in the last couple of years, and the number of kids that are sitting in the rooms looking at their computer screens, you can just imagine that what we're going to see in a couple of years. You can just, it's writings on the wall. So, in this disorder of self, over the last couple of years, we've called this developmental trauma. And we did that because post-traumatic stress was just put in around 1970 or 80, something after Vietnam. But a lot of the people we're seeing did not have post-traumatic stress. They had huge areas of neglect and abuse, and it wasn't PTSD trauma, it was more developmental trauma. And they were coming in with primary attachment problems. And in that time, we were trying to come up with a DSM setup for this. And one of them was we were trying to put in that self and relational dysregulation. Now listen to this for a minute and think about some of your clients. Intense preoccupation with the safety of the caregiver. They're taking care of their parents rather than parents taking care of them. Persistent negative sense of self. They hate themselves. Extreme and persistent distrust of other people in close relationships. Reactive physical or verbal aggression towards peers. Inappropriate, excessive, promiscuous attempts for intimate contact. Impaired capacity to regulate empathetic arousal, empathy. Now, have you seen this before? This is ubiquitous. This disorder of self, I see every day. And, what we're doing is we're trying to do cognitive behavioral therapy with people with disorders of self. It doesn't work. Because it's necessary but not sufficient. But if we don't properly assess it and diagnose it, it's not possible to treat it. And so, what does one do when one has a client with a false self, unable to form a relationship, has avoidant attachment? Well, you've got to name it in order to be able to treat it. So, I'm not big on diagnoses, but I am important on describing symptoms and knowing which symptom I'm trying to treat, and then coming up with the intervention for how to teach a person to become real. Okay? And that's psychotherapy. And you can't do it without really naming it and beginning to think about what causes it, and how to be able to work with it. You can say, well, how do you work with it? Our model is heavily internal family systems. So what we're trying to be able to do is have the person find these injured parts of self that are stuck in time and space and help them individuate, help them separate, and help them begin to differentiate and develop. So I think a lot of adults have been stuck at age 5, age 10, age 12. And the mistake with psychotherapy has been all of us have to be child therapists, because what we're treating is the child within the adult. And a lot of the disorders of self are injured children that are kind of stuck inside the adult. And so we have to begin to attune ourselves to the injured self and begin to, what we do is facilitate the adult self working with the injured self, which is the basis of more Gestalt kind of therapy. Okay, so intrapsychic means between the couple, intrapsychic is within the individual. So you're saying, well, how do you do marital therapy then with somebody who's got trauma and attachment disorder? And here's what we do. We'll see the couple, we'll give them Sensi Focus, and then when they come in and they have a block, we begin to work with that block. So let's say the woman couldn't take her clothes off because she was starting to have flashbacks. Well, we're going to then stop what we're doing and work with the woman on the trauma. But what we typically would do, if possible, is have the husband in the room. Why would we do that? Because what we found is that therapists steal intimacy from the dyad. Our clients are intimate with us, but not with their partner. And so what I'm trying to do is facilitate vulnerability and intimacy of the dyad. And so the model would be, I'm going to do a piece of work with her, and then I'm going to send them out after an hour therapy session and tell them to have coffee and to process what we just did in the hour of our office. So I want you to come in my office at 9 o'clock, I'll see you until 10, and then from 10 to 11, I want you to go out and sit and have coffee and talk about the session. And I want you to talk about what came up and process it with your partner. And that way, what they're doing is they're having the first intimate experience of their life. Because sharing someone deeply, they say, well, can somebody really be vulnerable with their partner in the room? I hope so, because that's what we're doing, marital therapy. And so often what I find is that men are telling me things that are incredible, and they've been married for 22 years, and their wife doesn't know half of what I know about them after knowing them for an hour. It's like, are you kidding me? So what I don't want to do is see them for a year and have an intimate experience with them at the expense of their marriage. And so I'm really fond, when somebody comes in for marital therapy, I don't like seeing them individually, because I feel like I'm just getting half the story, number one. And number two, they're not really learning how to be intimate with their partner. So I like opening somebody up and doing individual therapy with their partner in the room. It really works well. Sometimes you can't, because there's too much hostility or that kind of business. So I don't say this in terms of a cookbook, but it really is a powerful model. Then the most common difficulty that we're seeing is they say, are there any good men out there? Right? And what's the answer to that? I haven't seen any recently, have you? Anyway, no, it's just the ones you pick. The last 3 men who beat you up, and I don't think all men are going to beat you up, it's just the ones you pick. Why do I keep picking men who beat me up? That's a good question, right? And there is an answer to that. I mean, there's just a whole set of literature on reenactment and repetition. That paper that you got when you came in, I write papers every once in a while. And I've been intrigued with reenactment and repetition, so I wrote 3 papers on that, and I'd be glad to give you some, but it's in that article. And in it, I talk a little bit about the research on what causes people to go into repetition and reenactment, and teaching people to learn what their style is, and learn how to be able to pick partners that are good for them, and how to leave partners that aren't. So, the 2 groups that we have each week, one is called boundaries, and one of them is called codependency. And those are our most popular groups. The clients just drink in the stuff because they don't know what a boundary is, and they don't really understand codependency and reenactment repetition. Now, one of the difficulties is the love map. And as I said to you earlier, if we don't know what's, back when I was with Masters, we decided to do research on people's sexual fantasy patterns. Because there was not one piece of literature on what people are thinking about when they have sex with their partners. So we did a sampling, a large sampling of the general population. And we sat down and we asked them what they're thinking about when they're having sex. And it was our shock that most people weren't thinking about their partners. The men were thinking about their secretaries or somebody they had sex with a couple years ago. But women, in those days, there was an absence of any person at all. It was kind of an emptiness that was in there and a numbness. And if they had it, it was sort of like they would get colors or they would get sound. Zoom, zoom, that kind of thing. And we were listening to this sort of astounded. But think about it. If you're having sex with somebody and your mind is blank, maybe that's a break. And maybe that isn't such a good turn on. Why weren't women imagining images that would be arousing to them? Because there were so many taboos on shame and sexuality that they never really got a chance for rehearsals and practicing and building up their data banks. And so one of the things we started doing was teaching women how to fantasize and helping them begin to, within their value system. So we would give them lots of women's sexual fantasies and say, do any of these appeal to you? And kind of give them a sampling in some ways. Because part of the accelerator is if you're thinking about nothing, you're probably not going to get too aroused. So can you begin to develop fantasy patterns and arousal to stimulate you in some ways? That only made sense to us. And we call that the love map. And, a lot of them, I think, some of that's changed over time, again, since pornography. And maybe that's good in some ways, although, as you said earlier, I'm not so sure that, I want people thinking about Debbie Does Dallas while they're having sex with their partner. You know what I mean? Okay, so then it gets down to what is the model of marital therapy. In marital therapy, our basic approach was taken back in 1992. And in this, Freeman talks about unfinished business is an emotional reaction shaped by past experience. It's a reactive response guided by strong emotional feelings based upon the experience of anxiety. Unfinished business doesn't allow for a thoughtful, creative response to a here and now situation. Who we bring in our life, major life decisions, how we embrace important people, the amount of closeness and distance we need is shaped by unfinished business. Now, what does that mean? It means that instead of divorcing your husband or your wife or your partner, you ought to be divorcing your family of origin. And how do you divorce your family of origin? You begin to go back and look at what's unfinished in your relationship with your family of origin and begin to do that family of origin work and be able to get closure. One of our clients the other day, he hated his father, and so he called up his father on the phone, hadn't talked to him in years, and his father said, "I have no son." And he called up his mother, he said, "I'm going to come home, and I'm going to see you, I haven't seen you for 2 years, and can you drive me to the airport at the end of the week?" And the mother said, "Oh, we have another commitment on that day." Okay. Okay. So he went home and confronted that situation, and he was not reactive at all. After doing the family of origin work, he was with him in some ways, and he was not angry. He was not. He didn't fight with them. He didn't react to certain situations that were difficult. He was able to accept, radical acceptance, that which was. And he came out of there peaceful. And I thought to myself, now that's good trauma work. Because in the good trauma work, the goal of that is radical acceptance. And being able to go back and deal with your family of origin and not beg them to love you, not beat the hell out of them,
but finding some inner peace about what is and what was, and how it affected you in some way. And by doing that family of origin work, you're not going to then take that unfinished business and project it on your partner, because the cost of that is you're going to take whatever's unfinished and you're going to glue it on. Okay, that's psychodynamic marital therapy, and that's the basis of what we all do. And I somehow have got lost over the years a good bit, but how to do good family of origin work is always at the core of all psychotherapy, and everybody here knows that. But the element I would add, from having done trauma work for all these years, is that there's always a dissociative perspective. And that what Schwartz says here is, sexuality without sensuality needs investigating. The absence of a clear and coherent sense of being present in the body and experiencing the sensations associated with sexual activity, including the sensual one, is an indicator of the dissociative isolation of somatic experience and awareness. So there it is. Somatic-based psychotherapy is maybe 3 years old. It's not that old. Although there were a lot of people who were doing it years ago, but it wasn't as popular. But in that work, there's a greater recognition of the importance of emotions being in the body and teaching people how to get back in their bodies, experience the emotions in their bodies, and be able to express them in some ways. And so affect accelerated therapy, Dianaphosia, and a lot of the somatic-based therapies are teaching people how to be in their bodies in certain ways, the mindfulness revolution, and of course meditation. Of all the things that maybe have helped me personally, maybe it was meditation. Because in meditation, I learned how to control my mind and how to teach it how to be able to focus. And so all those distracting thoughts, I was able to somehow allow my mind to focus and have control over my thoughts. It took months to begin to have that. But now, like when I'm going to bed at night, I'm not distracted by all the things that come intrusive. I'm able to be present and be still. And the meditation has been most helpful at that. So if I was going to give somebody advice, I would tell them, go to a meditation and learn mindfulness and learn how to be in your body. Because so much of what happens in sexuality is a dissociative experience. But we haven't named that. And very few sex therapists have been trained in dissociative work. And that comes from working with trauma and working with eating disorders. And in it, you realize just how few people are actually in their bodies. Now, what Dan Siegel says to us is that health is the integration or linkage of differential parts and systematic wholeness that honors the differences between distinct parts. So in that, what we realize is that each of us has an injured part, and each of us has protective parts. And that then we have this sense of self. And so what Dick Schwartz says is that what we need to do is facilitate self-healing. And so the therapist is a catalyst and facilitates self-healing. And so what we do is we go inside that internal system and begin to use the self of the client to heal the injured parts of self. And so if a person comes in and they say, last night I had sex with a prostitute, what I do is I say, okay, let's focus now on last night. Can you go back to what you were feeling when you were walking in the room with a prostitute? And feel that feeling in your body. And there I go and I do a somatic bridge. And we go back to experience last night. And they move back into last night. And in it, we begin to get them into an altered state where they're actually bringing the sexual addictive part of self into your office. And that's different than your client. Because the client is Joe, and that's the person you got to know. But the person who was out with the prostitute last night, that part of self is a whole different part of self. And we got to get to know that part of self in order to be able to work with it in certain ways. I think that's part of the revolution of what we're doing in therapy nowadays. It's a much more gestalt, dissociative approach where we're beginning to understand that these parts take over and hijack the eyes and hijack the body. I mean, think about it. A priest
sits there and is caring and loving, marries people, goes to their funeral, and then molests the children. Like, how do you explain that? Okay? You can't without understanding dissociative phenomena, which is there's an injured part of self that's stuck there back in time, who's just a little kid themselves. And then there's the priest, and they're like a Dr. Jekyll and a Mr. Hyde. It's not multiple personality, but these are separate ego states. And if you're trying to work with Dr. Jekyll when Mr. Hyde is the one who's acting out, you're not going to be very effective. So learning how to bring that part of self into the room is the key aspect of that. So what we do is we use these dissociative experiences, and in the old days, Lori and I were trained in hypnosis, and we would learn affect and somatic bridges. And we don't use hypnosis anymore for a variety of reasons. So if a person has inhibited sexual desire, we're going to want to know who's in the bedroom. And it's not the person who's in your office, typically. It's a much more injured part of self that's stuck in time and space, frozen at T-1, and we have to begin to bring that part in. And what we're finding with people who have a lot of these intimacy disorders is that they're misusing the internet in that kind of a way, and it becomes a negative instrument. Yeah. All these things are both accelerators and brakes. And they have good aspects and bad aspects. So it's important to be able to look at both of them in some ways. Okay, so let's get some lay of the land. 17 to 41 million people present internet addictions. 17 to 37 million present sexual addictions or compulsive sexual behavior. 14 to 26 million have eating disorders. 6.9 million have gambling addictions and other addictive disorders. And so, why do I show you that? Because these problems, I mean, if you look around, most of us are filled and we're swamped and we're overwhelmed with what's coming in our door. I mean, we've had a waiting list at our place for almost 3 years now, just to get people in the front door. Just a number of people with these problems are just overwhelming, and COVID has just, pushed it off the scale. And so sometimes it's important just to step back and just notice what's going on. And what we find is that rarely does somebody have one disorder. So, we have Lee Larimore, who does work with 12-step, particularly with alcoholism and with drug addiction. And that I would say more than half of the people who come in also have a second addiction. So when they get their alcohol under control, their codependency goes up or their eating disorder comes in. In our eating disorder population, as we get the eating disorder under control, they start drinking or addicted to marijuana. And so it's kind of like one down, one goes up. And, our models of treatment are too focused on that. And so what we're trying to do is understand that these are comorbid disorders. And there's no such thing as just one anymore. And most of them have bipolar or some major psychiatric disorder that's underneath it in addition. And some even have autism. So what we're seeing are these people, there's no easy cases anymore. They're all complex. And they don't have one thing. And that's the problem. And so, as I keep saying, I think it's important to note what it is. And oftentimes the client won't tell you. They'll tell you that I'm here for chemical dependency or marijuana, but they won't tell you they have an eating disorder. Or they won't begin to look at the co-addictions for codependency. I think that all addictions are codependency addictions, and all addicts have intimacy disorders. Why do I think that? Because you're choosing a substance over a relationship with people. And there's a lack of connection with people in some ways. So,
Mark, you have a question?
yeah.
This may be silly, but it's almost like addiction to addiction.
Addiction to addiction.
Yeah.
It's like they have anxious attachment, like a little duckling looking for a mother, and if they can't find a person to connect to, then they'll find an object or a substance or whatever. And so you can get addicted to pornography, you can get addicted to suicide.
Yeah.
And
you know, a lot of what we work on, we're getting a lot of clients from CAMFT who, you know, tried suicide within the last 30 days, and they're just addicted to it. Every time they get stressed, they go to suicide. And so, you know, we're looking at it like an addiction model, and relapse prevention, and high-risk situations, and alternative coping responses. The same kind of thing. But you're right, it's addiction to addiction. Okay, so I brought a couple books with me today, and I thought during at the end, you might want to glance at some of them. And these are books that I use regularly. This is Clinical Management of Sex Addiction. This is Come As You All. This is The Sexual Healing Journey, which is Wendy Maltz working with survivors. And The New Male Sexuality, always the best book for men. And these are books that I give to the clients. And I thought you might want to sort of sniff through them, but they're good to have to give clients to sort of get started in some ways. Now let's say something about internet pornography. There are huge time distortions, harmful consequences, and they go into a trance. So what was really important to me after working with dissociative disorders for a period of time is to realize that these people are going into full trances. You know, it's like they go downstairs and for 2 to 3 hours, they're there till 3 o'clock in the morning and they're in a trance-like state. It's out of control, they're highly dissociative, and they're in a trance-like state. It's an altered condition. And so by looking at it as a dissociative disorder, you know, you ask yourself, how can you go out with prostitutes on a weekly basis for the last 10 years and then come home and be with your wife and kids? It's like, what's going on? And this is, you know, a nice person who, you know, goes to church every week, has conscience, and you're asking yourself, you know, how's that work, right? Like, what's going on here? And you realize that you can't really have a true sense of empathy for the person you're in bed with who you say you love if you're capable of doing such things. And so there must be something in the area of love. And what I find is that, Lori said it to me one day, she said that the blueprint of how an adult loves is written into how their parent loved them as a child. And so your capacity to love is blueprinted by the way your parents loved you. And that blueprint then manifests itself as an adult. And if your parents treated you like an object, if they cared for you by feeding and watering you, and they weren't able to have a true empathetic connection with you and sit down with you and ask you what you were thinking and feeling on a regular basis, if they weren't very attuned to your state, then as an adult, you think you love your partner by, you know, paying the bills, by feeding and watering, and all those kinds of things. And so what we're doing is having to teach people how to love. And that we're not really good at that because we don't even define love, you know. We don't have adequate definitions to say this person is capable of loving and this person is not capable of loving. But I would say that anybody who goes out with call girls on a regular basis and then comes home, jumps in bed with a partner, probably has an injury in their capacity to love. Would that be a fair statement? So how do you teach a person how to love, right? And the answer to that is what we try to do is we find out what's blocking them from being able to genuinely care for another human being. I'll tell you something. In my early career, I worked with child molesters. And I had, you know, probably more than 1,000 child molesters that I worked with in my 20s. And, you know, I was sort of, why does somebody do something like this? I couldn't imagine how a human being would do that to a child. It just didn't, nothing in my frame of reference had helped me understand that until I began to understand dissociation and injured parts of self. And then I began to understand the phenomenon. But in the end, what I decided was that the only way I could ever feel comfortable that I've treated a child molester effectively is when they had the capacity to feel true compassion for other human beings.
and know what it means to hurt a child. So what we used to do is bring the child molesters in with the women who had been molested. And people thought we were nuts. But the women who had been molested were angry as hell and wanted to confront their perpetrators. And when they did, these people who had been molested woke up and realized that they had permanently destroyed another human being's life because they had dissociated that out. And lots of good things began to happen. It wasn't a very popular model, as you may guess. But if you think about it, it makes all the sense in the world. Because, I mean, we were desperate. And these people were molesting 300, 400 kids before they got put in jail. And, you know, if you really care about kids, you want to do something to prevent that from happening. So we had to come up with something that was going to work in some ways. So now, why am I talking about this? Because in the end, if somebody is a sex addict and they're going out and doing all this weird stuff, in the end, what they have to do is they have to learn how to love and how to be enough in their body that they can feel empathetic feelings for other human beings. And so we're teaching them how to be able to love, and we're looking at what's blocking them from being able to love, which is, you know, so much hate and anger that, you know, came from, you know, being beat up as children. So that's how we begin to work with internet addiction. And I'll just, getting close to the end here, just tell you that there are a lot of problems with looking at porn. And we already talked about lack of interest in sex, becoming sexual arousal with partners later in life, having trouble reaching an orgasm, having intrusive thoughts that are interfering, and a lot of violence in your arousal patterns, feeling dissatisfied with partner encounters, and so on. And if young people knew what they were doing in terms of conditioning their brain and what the long-term effects was going to be, I think it would be really important. And so I think we're just at the beginning of doing primary prevention and teaching kids what they're doing, because, you know, it's ubiquitous. They're all looking at the internet and they're looking at sexual pictures, and we're not adequately preparing them for the potential damage. So there's this one study that was done in 2014, the Voon study, and what they found was that half the test subjects, 58%, had impotence with real-world partners after looking at porn at the ages of 11 and 12. And I think these data are really important because we're not adequately waking up to what's going on around us and how it's hurting our children.
Yeah, I mean, everything you're saying, obviously, since we've worked together, well, everything you're saying since we've worked together for years, I've primarily agreed with, of course. But if kids knew the long-term effects of looking at porn all the time, it wouldn't make a damn bit of difference, because it's like the war on drugs. As long as people need drugs to anesthetize themselves, then drugs will continue to become available, and, you know, they'll be in epidemic proportions. So, I mean, pornography is a drug.
Except for if they know they're going to be impotent, it might make a difference.
Yeah, but it wouldn't, because you think it won't happen to you when you're a teenager or an adolescent. You think you're, you know, somehow the exception to the rule. If you remember being 12 or 13 or 14 or 15.
Being impotent really scares the shit out of me.
Okay, well, maybe you're right then. But in any event, I think what would be more useful is to figure out what you said before. What are the blocks to actual connection that are endemic in culture even more and more? Because, I don't know, people had a lot of sex during the 80s, as I recall. But you know, people made each other breakfast before sending the person away. I mean, there was a certain way of being around sexuality that I think people don't even, young people, a lot of them don't seem to even have any frame of reference for. And it's like for some reason, the interpersonal connection piece of it fell out even more as time went on. And I think that's the thing that we need to look at as well.
Instant gratification.
That too.
Yeah, what, a good third of our population are on SSRIs. SSRIs completely knocks out your sex drive. And I don't think anybody's having sex. So we don't really need to have this workshop because no one's really having sex anyway, right? Get my point? It's funny, but it's not. That we have this huge epidemic of sexual problems in our country. And that we talk a lot about it, we watch a lot about it, but a lot of people are not having sex. And I think it really seriously injures marriage and intimate relationships. And SSRIs have, and most of the psychiatric meds actually, have a major side effect of killing the sex drive and increasing the appetite. And that's a problem. And fortunately, there are more and more drug companies that are trying to make formulations. And so we've been using more Vraylar and Capilida recently because they advertise that they have much less side effects of medication on sex and on eating. And they probably do. I mean, that Wellbutrin, those three, seem to be the ones that are less in that way. When they work, it's great. When they don't, we have a big problem. So you have your choice. Do you want to be depressed or do you want to have sex? And that's unfair. So, we've got to figure that out. Okay, so let me just summarize, because I know this has been sort of overstimulating. What I tried to say was that you always begin with cognitive behavioral therapy. And sex therapy is a really robust kind of intervention that really works with 80% of cases. But as the years went on, what we found was that the cases that were coming were far more complicated. And so we had this epidemic of people with PTSD, sexual trauma. And we had to figure out how to incorporate that into our sex therapy. And it was necessary that be part of the sex therapy process, but not by doing individual work with somebody, but trying to work within the relational dyad. As we did that, we realized that PTSD trauma work was necessary but not sufficient. But we had to begin to work more with the early attachment environment and begin to look at these disorders of intimacy and disorders of self. And these require much more family of origin work and depth kinds of therapies. And so what we fight against are these programs that kind of do just 12-steppy kind of work or just cognitive behavioral work. And we see that as all necessary, but just the first step of treatment. And what has to happen underneath that is the deeper work of beginning to work with people around the issues in their development. So what I do is I'm interested in developmental psychopathology. I'm interested in looking at the developmental experience of developing psychiatric problems. And as we begin to name these deficits, then we can begin to think about interventions for them. So we've been working really heavily on these attachment disorders, intimacy disorders, and disorders of self and love, and coming up with psychotherapy techniques that can work in a time-limited setting to have people come back into their bodies from that dissociative experience and learn how to be able to love both themselves and others and stop all that shame that they experience inside of self-hate. And that becomes the target of the psychotherapy model. And I'm probably just preaching to the choir because I'm sure all of you do that same work. But it's helpful sometimes just to have somebody validate that and be able to say, yeah, that makes sense, to put it in a full gestalt like that. And in this article that I give you a copy of, I try to put that in print because a lot of it needs to have a database to it. So I give you the basic research that is behind that. Yeah. So if they're in your office, the question is, why are they in your office? So I always start with that. And if they didn't have a problem, they wouldn't be in your office. And so I'm trying to take the problem and tie it into the symptoms. So if the parents are bringing them in because they're depressed, then or anxious, that's obviously where I'm going to start. And then when we get down to the pornography addiction, I try to understand the function of the symptom. Why are they using pornography? they're oftentimes very isolated, very lonely, have social anxiety, unable to interact with people. And so I'm not going to take something away until I understand its function and what's working. So it might be that I'm going to work on social anxiety. It might be that I'm going to work on, at home, there's lots of dysfunction and disorder. It might be that they're doing marijuana. I mean, you can't take it out of the context of the gestalt of everything that's going on. And so once I develop a therapeutic relationship, then I'm going to help them see how, what they do when they get anxious is they turn to marijuana and then they turn to pornography. And so how do you get somebody to stop doing marijuana when they're addicted to it, when they're doing it from morning until night? Well, you don't just sort of go in there and say, stop it. What you have to do is use your relationship with the client to show them how their life is completely out of control and begin to bring them in to beginning to create a life worth living for themselves. And so they begin to see how they're using pornography and how it's hurting them. And usually they'll say to you, I don't like what's going on. It doesn't feel good. It's necessary, but it's not desirable. And that's the definition of addiction. It's necessary and distressing. And if you take the distressing piece of it, you can say, do you want my help in getting under control of this? And if the person says yes, then we're going to start with abstinence. And yes, all addictions start with abstinence. And so how do you get somebody to be abstinent from pornography when they're, 16 years old? That's a good question. And, what I do is I give them a net nanny, and there's several net nannies, and I wipe it off their computer, and I get it so that it comes on my computer. And which reports directly to me. So there's 2 or 3 of these net nannies that I just throw into their devices with their consent, and I'm going to try to, like if you've got somebody who's doing marijuana, you've got to check their urine and find out if they're using marijuana or they're going to be lying to you. You've got somebody using pornography, you have to have some way to get under control of it. So these net nannies are very powerful in the sense that you can have it report to you, you can have it be blocked from their computer. There are a lot of ways to be able to do it. If they're masterminds, they can get around some of them, but it's hard on the newer ones. So I hope what you see is I don't, I'm not going to go in like a 12-stepper and you're going to have to cut that out. It's a much more kind of slow relational model of working with them and helping them see that they're injuring themselves, and I want to stop them from injuring themselves. Does that work?
Yeah, thank you.
Did you call them what, net nannies?
Net nannies. You just go on Google and say net nanny, and you'll get 20 of them. These are computer net nanny. They're computer programs that block people from looking at pornography. And I can have it so their wife gets, if they go on any sex site, including cruising for sex, it will immediately go to their wife's computer. So, there's a way to be able to want it. I don't like putting the wife in the policeman position. I'd rather be in it. So, thank you.